Work. It is with great pleasure for me to introduce a friend and colleague, Heather Pines, who is an assistant professor in the UCSD Herbert Wertheim School of Public Health and Human Longevity Science, as well as the Division of Infectious Diseases and Global Public Health in the Department of Medicine. Dr. Pines, excuse me, received her BA in molecular and cell biology with an emphasis in immunology from the University of California, Berkeley, her MPH in epidemiology from the University of Washington, and her PhD in epidemiology from the University of California, Los Angeles. Her expertise lies in the measurement and analysis of behavioral and socio-contextual factors that shape HIV and STI transmission dynamics and prevention behaviors. Her current research aims to guide the development of HIV and STI prevention programs that leverage information about social and sexual networks to target the delivery of prevention strategies and interrupt transmission within key populations disproportionately affected by HIV STIs in the US and the Mexico-US border region. I will hand it over to Heather in just a moment. Just as usual, our normal housekeeping rules. You can put messages in the chat if you want to send something to me privately. I'll be keeping an eye on things. I will try to only interrupt Heather for clarification questions unless something seems like it's really important to discuss in the moment. And then hopefully we'll have some time at the end for some lively discussion. And with that, I will hand it over to Dr. Pines.
Great, thanks so much, Jill. It's nice to be here with you all this morning. I'm going to be talking about some work that I have done in Tijuana, a project where we compared the effectiveness of respondent-driven sampling and venue-based sampling for identifying undiagnosed HIV infection among MSM and trans women in Tijuana. So let's get started. I do not have any disclosures. This is just an outline of what I'll cover today. So first, I'll briefly introduce the epidemiology of HIV among cisgender men who have sex with men and trans women in Mexico. Then I'll give you an overview of the HIV risk environment and barriers to HIV testing. And then this will provide the context for a study we conducted called Proyecto Enlaces, where we compared the effectiveness of these two sampling methods to detect undiagnosed HIV infection. So as we've seen in other low and middle income countries globally, including those in Latin America, Mexico's HIV epidemic is concentrated among key populations, particularly MSM and trans women. In Mexico, the prevalence of HIV within these populations is estimated to be about 17%, which is 85 times that among reproductive age adults in the general population who have an HIV prevalence of 0.2%. And Tijuana is a major Mexico-US border city. It's situated within the Mexico-US border region that I'm showing you here on this map. And I'm assuming that most of you are aware or familiar with some of the work that's been done by colleagues here at UCSD to characterize the HIV risk environment in the Mexico-US border region. But I want to sort of quickly summarize that work because it provides the context that's relevant to the design of Proyecto Enlaces that I'm going to be talking about. So the risk environment can be characterized by a number of socio-contextual factors, including things like poverty, migration, substance use, commercial sex work, and stigma towards sexual and gender minorities. And these things often intersect within populations most affected by HIV in the region to then facilitate HIV transmission and limit access to HIV care and prevention. And we can start to understand the impact of the risk environment on access to HIV care from this figure. So here, this figure is presenting the results from a pooled analysis of data from over 3,000 participants across 6 studies that were conducted with key populations in Tijuana, and included MSM, people who inject drugs, and cisgender female sex workers. And as you can see, of the 191 persons living with HIV, only about 11% were aware of their HIV positive status, and then less than 5% were receiving antiretroviral therapy. So at first glance, this is somewhat perplexing because universal access to HIV care, including antiretroviral therapy, has been available in Mexico since 2003. But actually, the drop-off we're seeing here in this figure is pretty easily understood and explained by access aspects of the risk environment that I mentioned before. So Things like stigma and discrimination towards sexual and gender minorities, sex workers, and people who inject drugs are quite common in this setting, which often limits the provision of culturally competent HIV care that's specific to the needs of key populations, which then limits their uptake and continued use of HIV services. Migrants in the region, particularly deportees, also face additional challenges accessing free HIV care if they don't have documentation of their Mexican citizenship. And another important aspect is that the Zona Norte, which is the neighborhood just adjacent to the Mexico-US border, that neighborhood overlaps with the red light district, as well as venues where MSM and trans women gather to socialize and meet sex partners. So there's a concentration of key populations in that neighborhood, and it's about 25 kilometers away from the local Capacites, which is the government-funded HIV clinic locally in Tijuana. And so on public transportation, being that far away from the Zona Norte, it can take around half a day to get there. So you can imagine it poses significant barriers to accessing HIV care being so far from the Zona Norte. So considering these data in the context of Mexico's universal access to care and ART, and then the known barriers that the risk environment poses to accessing HIV care, really speaks to the need for interventions to enhance engagement with the HIV care continuum, and particularly early stages of that continuum related to HIV testing, since that's where we see the greatest drop off among these key populations. So here we have data from 2 pilot studies conducted among MSM and trans women in Tijuana. The first found an HIV prevalence of 22% among 100 trans women. And of those who tested positive, 40% were previously unaware of their HIV status. And then the second study found an HIV prevalence of 20% among MSM and trans women. And of those who tested positive in that study, 89% were previously unaware of their HIV positive status. So in both these studies, HIV prevalence was high, but it was also consistent with the prevalence estimate in Mexico overall that I showed you earlier. So what was most sort of alarming from these studies was the high rate of previously undiagnosed infection. So let's look at testing history within the pilot study conducted among MSM and trans women. There, we found that 64% had ever been tested for HIV, but only 37% had been tested in the past year. So only about a third were adherent to current WHO guidelines that MSM and trans women should undergo HIV testing about annually. We also looked at barriers to HIV testing, and we found that some of the more common barriers could be described as individual or attitudinal barriers. So things like, I worry that testing HIV positive will change my life. That was most frequently reported at 54%. And then that was followed by, I'm at low risk for HIV. HIV test results are not confidential. I'm too healthy to be HIV positive. So many of these barriers suggest that fear and low perceived risk and also low knowledge of HIV may be impeding uptake of testing. But other barriers that were cited by about a third of participants included things like there's no testing on weekends or after hours, getting tested costs too much, I don't trust clinics and I'll be discriminated against if I test positive. These sort of suggest that socio-structural factors related to the HIV risk environment may also be limiting testing uptake among MSM and trans women in this setting. So collectively, these findings sort of point to a need for culturally appropriate, maybe active approaches to better engage MSM and trans women at greatest risk in testing. And they also speak to the need for high quality, confidential testing that's available in conveniently located, non-stigmatizing settings, and also with flexible hours. So there was a lot of rich data and interesting findings here, and helped understand why testing rates were so low. Fortunately, there are several active approaches that have been used to reach these populations and provide HIV testing in a way that overcomes many of the individual and structural barriers to testing in more traditional clinical settings. And these include things like partner contact tracing, venue-based sampling, and respondent-driven sampling. So partner contact tracing, or PCT, is commonly used by public health departments throughout the US and to varying degrees in low and middle income countries. where the goal is to engage high-risk persons in HIV testing. And it's implemented by interviewing newly diagnosed persons to elicit their recent sex or drug use partners so that they can be notified of their potential exposure and then referred for HIV testing. VBS and RDS were originally used in HIV surveillance and research to generate representative samples from socially marginalized populations and then produce population HIV prevalence estimates. But they're now also used in HIV prevention. So VBS attempts to approximate a probability sample by mapping the universe of venues frequented by members of a target population and then generating an understanding of the days and times that they tend to be present at those venues. And then using VBS, individuals from those venues are randomly selected or approached during randomly selected venue day time slots when outreach workers are present at those venues to invite people to be tested for HIV. So VBS could be utilized to identify members of the target population for testing. But a drawback of VBS is that it's limited to venues that are accessible to researchers and the people who frequent those venues. So RDS can overcome that limitation by sampling members of a target population through their social networks. RDS is a chain referral sampling technique where initial seeds are recruited and then incentivized to recruit their peers to the study, and then eligible peer recruits are incentivized in the same way to recruit their peers in subsequent recruitment waves. But RDS, like VBS, has its drawbacks, and it can generate bias samples because recruiters tend to recruit others like themselves. And while these biases or limitations could be problematic if the goal is to generate a representative sample, it doesn't hinder the use of either VBS or RDS for the identification of undiagnosed HIV. And strategies like RDS are now recommended for HIV testing recruitment by both the CDC and the WHO. So in the project that I'm going to tell you about in a few minutes, Proyecto Enlaces, we initially designed it to compare the effectiveness of PCT and VBS for identifying undiagnosed HIV among MSM and trans women. But after about 9 months of implementing PCT, we halted it and switched to RDS because it was less acceptable and sort of feasible in this setting than we had expected. And some of the challenges we faced were we had a hard time identifying index cases. It was hard to obtain reliable partner contact information because of the high frequency of anonymous sex partners. And then there was also, when we were able to identify or notify partners, testing uptake was often pretty low among those notified partners. So I'm not going to say too much more about PCT, but I'm happy to discuss that part of the study later if there are questions. So I'm going to focus more on the RDS and VBS, but I want to sort of talk about what we already, before doing this study, knew about the two with respect to their effectiveness for identifying undiagnosed HIV. So it turns out that several international studies have demonstrated that RDS and VBS are useful for generating samples of MSM and trans women for surveillance and research, like I mentioned before. But they've also been effective for identifying undiagnosed HIV among MSM and trans women. And a few studies have also examined their relative effectiveness among MSM and trans women in the US. And those studies found differential levels of effectiveness that really varied depending on the context. So some finding that VBS was more effective, some finding that RDS was more effective, and others really finding no difference at all. But almost all the studies did find that the socio-demographics and risk profiles of people recruited differed across the methods, suggesting that they're effective for engaging different segments of the population. But really much less is known about their relative effectiveness in low and middle income countries, particularly in Latin America, where stigma and discrimination toward MSM and trans women pose significant challenges to engaging these populations in testing. And so they could be potentially very useful strategies to increase testing and identify undiagnosed infections. So that was really our goal in this study, Proyecto Enlaces, or the LINKS project. And for the work that I'm going to be presenting today, our primary objective was to compare the relative effectiveness of RDS and VBS for identifying previously undiagnosed HIV among MSM and trans women in Tijuana. And then the secondary objective was to compare the characteristics of MSM and trans women who were tested for and then newly diagnosed with HIV by recruitment method. So moving on to our methods, we conducted venue-based sampling at venues identified through formative research as those that were frequented by MSM and trans women to socialize and meet sexual partners. And these included 34 physical venues, things like bars, clubs, parks, plazas, one virtual venue, we ran ads on Grindr, and then 6 special events, things like gay pride. But before we started VBS at a venue, our outreach workers went out to obtain permission from the venue management to conduct on-site recruitment, and then determine the days and times MSM and trans women were present at the venues. And then that information was used to generate our sampling frame of 4-hour venue day time slots where we could expect to find MSM and trans women at the venues. Then between March 2015 and December 2018, during pre-selected venue day time slots, our outreach workers approached potentially eligible individuals about 5 days per week at the venues to tell them about the study and then screen them for eligibility if they were interested. And so in terms of eligibility, potential participants needed to be at least 18 years of age, cisgender male or trans female, report anal sex with men or trans women in the past 4 months, and also report no previous HIV diagnosis. But that last eligibility criterion was only required for testing. Previously diagnosed persons could enroll and contribute to other study aims that I'm not going to be talking about today. And then we implemented RDS from March 2016, so after we stopped PCT, through December 2018. So it ran concurrently with VBS. And we started RDS with 33 seeds that were selected to be diverse with respect to HIV status, age, socioeconomic status, sexual orientation, gender identity, and recruitment source. And then seeds were given 3 to 6 coupons to refer peers who were MSM and trans women from their social networks to the study. And then eligible peer recruits were themselves given 3 to 6 coupons to recruit their peers in subsequent recruitment waves. And both seeds and peer recruits were given 100 Mexican pesos, which is about $5 US, per peer recruit who presented at the study office. And then to be eligible to recruit peers, seeds needed to be at least 18 years of age, cisgender male or trans female, report anal sex with men or trans women in the past 4 months. And then to minimize the potential for unproductive seeds, people residing outside of Tijuana and individuals who had less than 15 MSM or trans women in their social networks weren't eligible to be seeds. And then RDS participants needed to be at least 18 years of age, cisgender male or trans female. And so that our recruitment chains wouldn't die out too quickly, we allowed MSM and trans women to recruit peers if they reported anal sex in the past year. But then for comparability with our VBS sample and for this analysis, we restricted the analysis sample to those who reported anal sex in the past 4 months, since that was the eligibility criterion for the VBS group. And then just as with VBS participants, those who reported a previous HIV diagnosis obviously weren't eligible for HIV testing, but they could enroll in the study and contribute to other study aims. So eligible MSM and trans women were then offered rapid testing at the recruitment venue if they were identified through VBS, or at our study office if they were identified through RDS. Those that were recruited more than once through either method who remained eligible were retested if it had been at least 3 months since their last test. And then rapid test results, post-test counseling, compensation of 150 Mexican pesos were then delivered within a few days at the study office for participants recruited through venue-based sampling, or immediately for RDS participants. And then those that tested rapid test positive, they provided an additional blood sample for confirmatory testing, and then were fully enrolled in a 12-month follow-up study. And they received their confirmatory test results within about 2 weeks, with referrals to Kappa seats for free HIV care and treatment. So as I mentioned, the newly diagnosed participants were offered enrollment in a 12-month follow-up study where they completed a baseline and then a 1-year study visit. And at baseline, they provided permission to abstract their HIV care data from medical records at Kappa seats so that we could look at who had linked to care over the year. But for 20 participants, we found evidence that they'd actually received HIV care prior to their enrollment in our study. So they weren't counted as newly diagnosed individuals in this analysis. And then at each study visit, participants completed interviewer administered surveys to collect socio-demographics, substance use behaviors, psychosocial factors, HIV knowledge and testing history. And then they also completed an egocentric sexual network inventory, which allowed us to collect detailed partner-specific data on up to 20 sexual partners. So this is just a summary of our study design. So once someone was recruited through either VBS or RDS, they were screened for eligibility. Then they were offered HIV testing. Those that were newly diagnosed were then fully enrolled in Proyecto Enlaces and followed for 12 months, while study participation was complete for those that tested HIV negative. And then in terms of our statistical analysis, to address our first objective, we used Poisson regression to compare primary and secondary outcomes by recruitment method. And our primary outcome was newly diagnosed HIV infection. Our secondary outcomes were any HIV infection. So that included both previously diagnosed and newly diagnosed persons. And other outcomes related to participants' level of engagement with study activity. So whether they screened for eligibility, whether they were eligible for testing, and then whether they actually underwent testing. And then to address our secondary objective, we used chi-square, Fisher's exact, and Wilcoxon rank sum test to compare the characteristics of participants that were tested for HIV, and then the characteristics of participants who were newly diagnosed with HIV by recruitment method. Let's see, and for participants that were tested more than once, we restricted our analysis to their initial recruitment date because we were interested in how these methods could lead to the identification of any undiagnosed infection, not necessarily incident infections among those who repeated testing many times. And so given our goal, we restricted to just the first recruitment and testing date. We would have needed a different study design to understand the ability of these methods to recruit individuals with incident infection. Okay, so moving on to our results. Through our VBS recruitment activities, outreach workers screened 2,560 persons across 1,071 sampling events between March 2015 and December 2018. And of those sampling events, 88% led to at least one person being screened, and 77% led to at least one person being tested. This map here shows our recruitment venues, which were mostly concentrated in the Zona Norte, the neighborhood adjacent to the border that I mentioned before. But there were also a few other venues dispersed throughout the city. And although the differences weren't significant, we did see a slight variation in the proportion of new diagnoses across recruitment venues, where the percent of newly diagnosed individuals was highest at our virtual venue. And then that was followed by bathhouses, bars or clubs, and then public spaces, and then sort of other, we identified 5% of individuals were newly diagnosed with HIV. So now let's talk about our RDS recruitment. So our 33 seeds led to the recruitment of 1,232 peer recruits across 18 recruitment chains. where the median the median number of waves across recruitment chains was 5.3. And if you're not familiar with RDS, I'll show you what I mean by that on the next slide. And the largest recruitment chain had 31 waves and consisted of 68% of our peer recruits. And then about half of seeds and peer recruits recruited at least one eligible peer. And peer recruits most commonly reported that they were recruited by a friend at 55%, and only 4% reported being recruited by a sex partner. So this slide shows our RDS recruitment chains where 15 seeds didn't recruit any peers, but our other 18 seeds led to the recruitment of 934 peer recruits across these different recruitment chains. The nodes with a green rim are the seeds. And so you can see this one seed recruited one individual, but this seed here, it's hard to see on this figure in the middle, led to the recruitment of 631 peers. So this is that largest recruitment chain that I was talking about, and it reflected 68% of our sample. And then this chain here on the right was our second largest. The seed is right here, and it consisted of 161 peer recruits, 17% of our sample. And one sort of interesting thing to note is where newly diagnosed HIV positive participants, who are shown in red, where they're located in these chains. We hypothesize that they might be clustered or linked to one another in these chains. And we do see a few instances of that, like I'm showing here with my pointer. But it's not as common as we thought it might be. And that might be because only 4% of participants were recruited by sex partners. We're currently working on some analyses to understand the characteristics of effective recruiters, or those who recruited at least one newly diagnosed peer, so that hopefully that could provide some insights into how RDS could be adapted, perhaps through differential coupon distribution to maximize the yield of newly diagnosed individuals. So that's something we're working on now. Okay, so let's look at our primary and secondary outcomes by recruitment method. Of the 132 persons recruited through RDS, 61% were eligible, and 97% of those were tested for HIV. And then that led to the identification of 36 newly diagnosed infections. And then of the 2,560 persons recruited through VBS who were screened, 57% were eligible, 93% were tested for HIV, and then that led to the identification of 82 newly diagnosed individuals. And then 8% and 9.6% of persons recruited through RDS and VBS respectively were either newly or previously diagnosed with HIV infection. So the majority of those living with HIV that were identified through either recruitment method were newly diagnosed or previously unaware of their HIV positive status, which maps onto the findings I showed you before from the pilot studies, where most persons living with HIV are unaware of their status. So here we're looking at prevalence ratios comparing RDS to VBS for our primary and secondary outcomes. And really not surprisingly, given the similarity of the distribution of the outcomes that I showed you on the previous slide across recruitment methods, all of these ratios are very close to 1, indicating that there was no difference in our primary or secondary outcomes. So with respect to our primary outcome, newly diagnosed infection, in this setting, RDS and VBS don't appear to have differed meaningfully in their effectiveness for identifying undiagnosed HIV. So now let's look at the characteristics of participants identified through each recruitment method. Here, we're looking at socio-demographics for those that were tested for HIV. And so those that were recruited through VBS were slightly younger than those recruited through RDS, with about 43% of individuals recruited through VBS being under 30 years of age, compared to only 20% of those recruited through RDS. Slightly more participants were recruited through VBS were trans women, 6.4% versus 1.6% among within our RDS sample. And then nearly 60% of RDS participants identified as bisexual, whereas roughly equal proportions of participants recruited through VBS identified as gay or bisexual at 40%. And here we're looking at socio-demographics, but this time this table is looking specifically at those that were newly diagnosed with HIV infection. And although the sample size is much smaller, we see similar sort of patterns to what I showed you on the previous slide. Those recruited through VBS were on average younger. Again, slightly more participants were newly diagnosed as HIV positive following VBS recruitment were trans women. But the distribution of sexual orientation was actually pretty similar among those newly diagnosed across recruitment methods. And then we can also look at additional characteristics among those with newly diagnosed infection, since they were fully enrolled in the 12-month follow-up study and then completed our more extensive baseline survey. And so here you can see that about 70% of participants recruited through VBS reported being employed, compared to only 53% of RDS participants. On average, VBS participants reported a longer duration of residence in Tijuana, 10 years versus 6.5 years, and a greater proportion of participants recruited through RDS reported a history of deportation from the US. And on average, participants recruited through RDS reported, here it is, greater levels of internalized stigma related to having sex with men or trans women compared to our VBS participants. We also found that slightly more participants recruited through RDS reported injection drug use in the past month at 17% versus 8.8%. And then slightly more participants recruited through VBS reported hazardous alcohol consumption at 40% versus 20% in the RDS sample. But there really weren't any meaningful differences in either sexual behaviors or HIV knowledge or testing history among newly diagnosed persons by recruitment method. So those are all of the findings that I have to share with you today. I do want to point out some potential limitations of this work. First, our use of self-reported HIV status during eligibility screening could have led to the misclassification of persons who were previously aware of their HIV positive status as newly diagnosed. But we were able to protect against that by identifying those who had previously accessed care at CAPA seats, which is where the majority of key populations access HIV care in Tijuana if they do. But also, since previously diagnosed persons were eligible to contribute to other study aims, they may not have been as incentivized to mask their HIV positive status during eligibility screening. Second, our findings may not be generalizable to MSM and trans women outside of Tijuana or even other cities in the Mexico-US border region. But our findings do reflect the ability of VBS and RDS to engage diverse subgroups of MSM and HIV testing to identify undiagnosed HIV in this setting, which was really our goal, not to generate representative estimates. And then finally, while we did detect meaningful differences between MSM and trans women that were recruited by the recruitment methods, our analyses among those with newly diagnosed infection were underpowered to detect statistically significant differences by recruitment method. So despite those limitations, we did find that the prevalence of newly diagnosed infection didn't differ by recruitment method, which might be explained by the fact that sexual risk behaviors and HIV testing history didn't differ by recruitment method. And as seen in other studies that have compared these recruitment methods among MSM and trans women, particularly or specifically in the US, our findings also suggest that each reached different subgroups of MSM and trans women in Tijuana. So compared to RDS, VBS engaged younger persons, both gay and bisexual identifying persons, and more trans women in HIV testing. And then among those that were newly diagnosed with HIV, employment and hazardous alcohol consumption were more common among those recruited through VBS, while deportation, internalized stigma, and injection drug use were more common among those recruited through RDS. And really many of these differences between MSM and trans women recruited through each method might be just due to the fact that VBS, especially when it's concentrated at gay bars and nightclubs, reaches MSM who are more out about their sexual and gender identity, or maybe more connected to the gay community. So what's interesting though is that although about 88% of our RDS seeds were recruited during VBS sampling events, through successive recruitment waves, RDS also appears to have successfully leveraged the social networks of MSM and trans women to reach more marginalized segments of these populations than can be reached by VBS alone. And I say more marginalized because there's a large body of research that's shown that those with a history of deportation, those who inject drugs, and those who are maybe less out about their sexual and gender identity are less likely to access HIV care and experience more exclusion from the healthcare system in Tijuana. So both are reaching important segments of the population, and perhaps RDS is reaching those that are more marginalized in this setting. So in conclusion, our findings really highlight the potential for both VBS and RDS to facilitate HIV testing among MSM and trans women in Tijuana. And while these methods may be equally effective for identifying undiagnosed HIV, the diversity of those recruited through each method suggests that there might be benefits to using both to enhance the identification of undiagnosed HIV among all MSM and trans women at elevated risk. So that's all that I have to share today. I just want to acknowledge all of our Proyecto Enlaces investigators, our really fabulous and hardworking staff that made all of this possible. We're out into late hours of the night recruiting at venues, and contributions of our study participants and funding from NIDA. And so I'm happy to take questions.
Those are some great shades, Heather, on that last slide. Well, that was a really interesting talk. What a great amount of work that you did, and some really interesting conclusions. I'm going to open it up. There is a question. I don't know if you want to look at the chat. I can read the question to you. You may have started to allude to this at the end, just with who is reached, but I can read the question out loud from Peter. What are the inferences that you can make for RDS and venue-based sampling for people who inject drugs in Tijuana, and maybe in particular female assigned at birth persons who inject drugs?
Yeah, that's a great question. So RDS was actually originally used to generate representative samples of individuals who inject drugs. So it has been used for that purpose, and in a lot of studies as a recruitment method with people who inject drugs, as well as in Tijuana. So one of the Dr. Strathy's El Cuete cohorts, I think it was El Cuete 3, used RDS to recruit people who inject drugs. And so it's very commonly used and not difficult to do within that population as a recruitment method. I'm hesitant to sort of say, oh, that the findings that we saw with MSM translate to people who inject drugs in terms of identifying undiagnosed HIV infection. But I certainly think it's feasible, given that it's an acceptable recruitment method and would be an interesting thing to look at. And it probably has been looked at. I'm just not as familiar with the literature on using this to identify undiagnosed infection among people who inject drugs, but definitely a feasible and widely used recruitment method.
Heather, I might have missed this. Oh, maybe. Okay. I have something, but good. All right. In terms of cost, which method will be more accessible or I guess useful in limited resource settings?
That's a great question. And we did do a cost utility analysis, which I thought I wouldn't have time to get to today, so I left it out of my slides, but clearly I would have had some time. We didn't find any difference in the cost of implementing either these methods for like cost per test or cost per diagnosis. That being said, it was not the most, so depending on the different thresholds that you look at, it might not be cost effective in this setting, the way that we implemented it. And so in our paper, we're going to discuss ways that these two methods could be adapted to enhance their effectiveness and cost effectiveness particularly. So, RDS is a little bit less time consuming for staff. It's less labor intensive than VBS. So that's a definite benefit there compared to venue-based sampling where staff need to be out there 5 days a week. At least that's how we implemented it to really reach this population. And so sort of weighing those pros and cons, one sort of adaptation that we're considering and that we think might be effective is since we used VBS, or individuals that were identified through VBS could serve as seeds, and that was really effective for us. And even though we identified our seeds from the venues, it led to reaching people who did not attend venues. Another adaptation might be to really make a stronger effort to nest RDS within the venue-based sample so that they're sort of working in tandem together. And that was showed to be cost effective in a study among MSM and trans women in New York City. So I think that, they're definitely cost effective in terms of there's data on, there are enough, they could be implemented with available resources as recruitment methods. And that's why they've been widely used in low and middle income countries for surveillance. But so the sort of bigger question is the cost per diagnosis part, which is what we looked at. And there were similar costs across the two methods, but maybe not yet crossing that cost effective threshold. It was a very long answer to your question, so hopefully I answered it.
Heather, I apologize if you said this. Did you look at the characteristics of the individuals who succeeded as seeds, and if there was anything that was, there were any behavioral or demographic factors that made them better seeds?
Yeah, so that's actually what we're working on now, to sort of characterize the effectiveness of our seeds, and then also, because the seeds just sort of recruit their 3 to 6 people, but then as well as the peer recruits, because they're out recruiting as well. And so we're trying to understand both effectiveness for just recruitment in general, but also effectiveness who gets to more newly diagnosed persons. The one thing that I found really interesting is, so that largest recruitment chain that we had was from a seed that we recruited from Kappa Seats, the main HIV clinic in Tijuana, a person living with HIV, and she was also a trans woman. So it's just sort of like, our sample was predominantly MSM, but I think it speaks to sort of the interconnectedness of these populations, as their social networks are definitely overlapping. And so, yeah, that was an interesting sort of finding for us. And we definitely are exploring that further.
Thanks. I will ask one more because it sort of leads to the project that we are working on together. But what are the implications for this with respect to HIV prevention? And what, how can we use your findings to work on, all aspects of the cascade, the before and after parts?
Yeah, so I think, that's sort of part of we're just getting people with our study, we were just getting people in the door to talk about HIV testing really, but then that also served as an opportunity to talk about prevention and make referrals for services as needed. Certainly the people that were diagnosed with HIV, we attempted to, or we made referrals to Kappa seats and we supported them to get there as best we could. But I think that there's opportunity to build sort of interventions on top of this, right? So we could start to understand, okay, well, for whom does just the simple referral work after being recruited through RDS, and then what kind of interventions or additional supports could we build in to ensure that you know, people that are either newly diagnosed with HIV, or maybe we identify some that have been living with HIV for a while but not engaged in care, how can we improve that, move along the continuum a little bit further. This is just a really great way to get people in the door to start sort of like providing the services needed, because they're not seeking them out on their own.
Thanks, Heather.
And PrEP is not yet available, but you know, one day when it is widely available, I hope in Mexico, then you could also couple sort of referral and think about ways to use this method to facilitate engagement with PrEP care.
Great. Does anyone else have any comments or questions? You can either put it in the chat or unmute yourself if you'd like to. I guess it's one of those quiet mornings.
The quiet gray morning.
Or you just answered everything so well and there's no room for further discussion. No, that was great, Heather. All right, well, we also are happy to end things a little early. I think, you know, next time we have you back, wink, wink, you also are, you know, more than welcome to share some of your cost effectiveness data. I think there are a lot of people, obviously, that's very, you know, that are very interested in that. Well, probably most of us, although we may not have a great understanding of it all. So in the future, when we have you back.
Sounds great.
Thanks so much, Heather. It's always great to hear from you. You are such a good and clear speaker, and I think make this very, very easy to digest. So thank you.
All right. Well, thank you all for listening, and it was fun to be here. So thanks.
All right, everybody. Well, hope everyone has a safe and healthy, safe is the most important word, holiday weekend. And we'll be back together in a week. Thanks, everybody.